Video 58, Analyzing Policy Area VM Chess Subcompetencies 5.3.2. Review the learning objectives for this video. Welcome back. You have made a great decision to keep pushing through Area 5 because this next topic is going to bring together everything you have been learning about advocacy into a more analytical framework. Policy analysis is a systematic process for evaluating policy alternatives to determine which approach is most likely to effectively address a specific health problem. As a health educator engaged in advocacy, policy analysis helps you make evidence-based recommendations about which policies to support, oppose, or modify, rather than advocating based on intuition or ideology alone. Effective advocates ground their positions in rigorous analysis. Policy analysis examines multiple dimensions of each policy option. First, it considers costs, asking what financial resources are required for implementation and ongoing operation. Second, it examines benefits, identifying the expected improvements in health outcomes, quality of life, or system efficiency. Third, it assesses feasibility, determining whether the policy can realistically be implemented given existing infrastructure, workforce capacity, and administrative systems. Fourth, it evaluates equity, asking whether the policy will reduce or exacerbate health disparities across population groups. Comprehensive policy analysis also considers unintended consequences, and this is something I really want you to keep in mind. Every policy creates ripple effects beyond its primary intent. A sugar-sweetened beverage tax may reduce consumption but could disproportionately burden low-income families. A mandatory vaccination policy may improve herd immunity but generate political backlash that undermines trust in public health. Good policy analysis anticipates these secondary effects and accounts for them in the overall evaluation. Finally, effective policy analysis integrates three streams of information. Scientific evidence tells you what works. Stakeholder perspectives tell you what is acceptable. Political context tells you what is possible. On the MChess exam, policy analysis questions often present a scenario with multiple policy options and ask you to identify the most appropriate evaluation criteria or the most effective policy choice based on stated goals. You are building exactly the analytical skills you need for those questions. Now let us look at two analytical frameworks that frequently appear on the MChess exam when evaluating health policies. Understanding how they differ is essential, and I know you are going to be glad you spent time here. Cost-benefit analysis, or CBA, measures both the costs and the benefits of a policy in monetary terms. This means you must assign a dollar value to everything, including health outcomes. For example, you might estimate the dollar value of a prevented heart attack by calculating saved medical costs plus lost productivity averted plus the statistical value of life years gained. The advantage of CBA is that it produces a single number, the benefit to cost ratio, that allows direct comparison across very different types of policies. If a tobacco control policy has a benefit to cost ratio of 3:1, it means every dollar spent generates $3 in benefits. If a seatbelt enforcement policy has a ratio of 5:1, you can directly compare the two. However, the major criticism of CBA is that assigning dollar values to human health and life is ethically controversial and methodologically challenging. Cost-effectiveness analysis, or CEA, avoids this problem by measuring costs in dollars but keeping health outcomes in their natural units. Common units include quality-adjusted life years, or QLEs, disability-adjusted life years, or DALYs, cases prevented or life years saved. CEA tells you the cost per unit of health outcome. For instance, screening program A costs $50,000 per QALY gained, while screening program B costs $30,000 per QALY gained. Program B is more cost effective. The limitation of CEA is that it can only compare policies that produce similar types of health outcomes. You cannot easily use CEA to compare a vaccination program measured in infections prevented with a mental health program measured in depression-free days. Here is a simple way to remember this for your exam. When a question asks about comparing the financial return on investment of a policy, think CBA. When it asks about the most efficient way to achieve a specific health outcome, think CEA. That distinction is going to help you tremendously. Now let us talk about something that connects your analytical skills to the real world of advocacy, and this is a critical concept for the MCHES exam. Even the most evidence-based, cost-effective policy will fail if it lacks political feasibility. Political feasibility refers to the likelihood that a proposed policy can gain enough support to be formally adopted by the relevant governing body, whether that is a legislature, school board, city council, or organizational leadership. A policy might be scientifically sound and economically efficient, but still politically infeasible because it faces strong opposition from powerful interest groups, lacks public support, or conflicts with the dominant political ideology of the decision-making body. Political will is the closely related concept of whether decision makers are committed to addressing a particular issue. Political will exists when elected officials or organizational leaders are willing to invest political capital, meaning they are willing to take risks, spend money, and potentially face opposition to advance a policy. Political will can be built through advocacy, and this is where you as a health educator play a crucial role. Stakeholder mapping is a practical tool for assessing political feasibility. You identify all the individuals and organizations that have a stake in the policy outcome and categorize them as supporters, opponents, or persuadable. This analysis tells you where to focus your advocacy resources. You want to energize supporters, persuade the undecided, and either neutralize or address the concerns of opponents. John Kingdon's concept of the policy window is also testable on the exam. A policy window opens when three streams converge: the problem stream, meaning the issue has gained public attention; the policy stream, meaning a viable solution exists; and the political stream, meaning decision makers are ready to act. These windows open unpredictably and close quickly, so advocates must be prepared to act when the moment arrives. Health educators build political will through several strategies, including presenting compelling evidence to decision makers, mobilizing community members to contact their representatives, using media advocacy to shape public opinion, and building coalitions that demonstrate broad support for the policy. You are really connecting all the dots now between evidence, strategy, and real-world impact. That is exactly what the exam is looking for. Read the scenario stem aloud. Give students 30 seconds to consider options before advancing. The correct answer is B. Cost-effectiveness analysis is the most appropriate framework because both policies target the same health outcome, prevention of new adolescent e-cigarette users, and can be directly compared using cost per case prevented. Policy A costs approximately $133 per case prevented, while Policy B costs $500 per case prevented, making Policy A more cost-effective. CBA would require monetizing the health benefit of preventing e-cigarette use, which is unnecessary when both policies produce the same outcome type. ROI is a financial metric, not a health policy evaluation tool. A needs assessment is a separate process that would have already occurred before reaching the policy evaluation stage.